It is 8:10 on this Thursday morning, and we have the folks from Common Sense Matters are here.
Good morning, and welcome to Common Sense Matters. My name is Sandy Rice, and we've got a good program for you on the opioid crisis. First, I want to make one announcement for the Franklin County Democratic Party. The annual fundraiser and rally will be on April 7th, beginning at 5:30. It's a bean supper and a chance to meet local and statewide candidates for office, as well as other Democrats across the county. Tickets are $10 for those over 12. They're available at the door, or you can contact Bob Zimmerman at 308-7202 or any Franklin County Democratic Party member. So that's April 7th, beginning at 5:30, and I have not written down the address, so we'll talk about that more in at the next program too. My guests today are Stephen Mason, who is a peer recovery specialist with Franklin County Prevention Coalition and Tennessee Save a Life. Also Josh Cruz, who's a regional overdose prevention specialist who's newly hired by the coalition, and a paramedic. Welcome, guys. I want to start with the basics of our topic today because there's so much on the news and in the paper about this national public health crisis of opioids. Josh, can you tell us what is an opioid?
Well, an opioid is a substance or a medication that specifically acts on what's called opioid receptors in the brain. And in mild doses, it causes stimulant to the body, and in higher doses, they use it for pain relief and anesthesia to put people under for surgery, and they use it for long-term pain relief as well.
Okay, so what are some examples of medications that would be considered
common
an
opioid medications are hydrocodone, morphine, meperidine, Demerol, fentanyl. There's illicit fentanyl that is also coming in it's illegal, and heroin also is illegal. It's considered an opioid. And Suboxone is another common opioid. That's one that is used to try to get people off of heavier opioids, and there's quite a list of them.
Okay, oxycodone and Oxycontin are something people may be familiar with. Dilaudid. Mm-hmm. Okay. So what is addiction to these drugs? What is considered addiction?
I'll answer that.
Steve? Okay.
Addiction is where, we have to kind of categorize this as it's not just dependence. Addiction is where if I'm dependent on the medication, which it is, it is easy to develop a dependence, but after I'm through the withdrawal symptoms, I go back again and again and again. It's characterized by the craving brain, where the brain craves the dopamine rush that the medication provides.
So, do addicted patients have pain?
I would say...
or it might start out as pain and then it's just the craving after that?
Well, it
can be.
I mean, addicted patients, I'm sure they have pain just like anybody else. I was an addict for 11 years. During that time, I had pain. And then, do pain patients have addiction? I think that not all pain patients have addiction, and not all addicts, or some addicts have pain,
Okay, so the main thing is this change in the brain that wants more and more and will do anything to get that. How did this opioid addiction become such a problem?
Well, I think that it's not just one thing that caused it. There's multiple levels here. When narcotics were originally created for medicinal use, I do believe that the intention was good. I don't think they fully understood what the long-term effects of using opioids and narcotics would have on the brain and on people in the long term. And then the shift of the hospitals to shift it as a patient-driven system where the patient gets the right to say, my pain level is such and such on the pain scale, and that if the patient's not satisfied, then the hospital gets in trouble, push them to start treating people more because people want their pain gone. They don't, when the original intent was to dull the pain to a manageable level. And now we're at the point where people want the pain gone. They want to be 100% satisfied with it, and then that led to other problems. And then, of course, you had heroin that's been around for many, many years coming in from out of country. And so now you have people who are using the lower-level opioids, like the legal ones, and then when they don't get the high that they need anymore because their body builds up a resistance to it, they go to stronger and stronger, higher doses, and they start reaching out for illegal drugs. And so it's a multifold system. Part of it had to do with the pharmacy companies. Part of it had to do with the doctors who are writing the prescriptions, and part of it has to do with the illegal drugs coming in and the mindset of society in general. There's multiple levels. It's not just one person to blame.
Yeah. And on a personal level, I was in the middle of this. I was a young nurse in the 80s, and pain became the fifth vital sign. So temperature, pulse, respiration, blood pressure, and pain.
On a scale of 1 to 10.
A scale of 1 to 10, and then for your pediatric patients, you had the faces.
Right.
And so the Joint Commission, who monitors hospitals and care received in hospitals, really would get after you if a patient didn't have a 0 or 1 degree of pain. And then also the pharmaceutical companies really gave inaccurate information. By this time I was in hospice care, and I was providing hospice care and working with cancer patients. So we had a physiological basis most times for pain, so I'm not going to be completely guilty for all this. But we were told that the long-acting pain relievers like OxyContin, which can last for 8 hours, the construction of that tablet just releases medication over a period of 6 to 8 hours, and fentanyl patches up to 3 days, that they weren't addictive. Because, and so, up until the 2000s, we kind of, believed the information, on that, and we're finding that wasn't the case. They're all addictive if they're an opioid. Okay. Let's start with Franklin County. How much of a problem do we have here?
We as far as I think in two. Let's see. I don't want to give wrong information. I'm not for sure. So I don't know how many overdoses we had last year, but I know as far as like pain pill prescriptions per person, we are right there with the rest of the state. Actually, I think we're a little bit higher. I think we're 1,400 for every 1,000 people pain pill prescriptions.
No.
So there are more pain pill prescriptions in this county than there are people.
Okay.
And that doesn't include the illegal drugs that you can't account for. That's just the prescriptions being written by doctors that's being tracked.
Okay. Do you have state overall deaths in 2016 or overdoses? I'm not sure how they...
They were, in 2016 there was over 1,600 deaths due to overdose, and that was a over 200 person increase from 2015, and it went up 200 from 2014, and we have statistics in the program that we give all the way back to 2011 where it was less than 1,000, and it went up by 20 and then 40 and then 40 and then 200 and then 400, and the statistics for 2017 I expect will be well over 2,000 people dying from overdose in the state of Tennessee alone.
Tell us about the coalition, your mission and programs in our county.
The Franklin County Prevention Coalition, just like any other prevention coalitions, its main target is to, or its main mission is to identify problems in the community with tobacco, alcohol, substance use, period, and come up with a game plan to stem that problem and come up with a solution. And they do that through partnerships within the community. So the coalition is actually made up of the community. We have a central office, and within that office we have it ranges from anything to parenting classes, classes for at-risk youth, MRT, moral recognition therapy for the youth. A lot of preventative measures with our youth. That's what takes place at the coalition. But we have, of course, Tennessee Lifeline, which is our Lifeliner is Alan Burnett, and he gets individuals into treatment. And the whole point of that campaign, that program, is to get individuals into treatment, to offer recovery support, get them plugged into 12-step meetings and other support groups in their communities. And he services not just Franklin County, but 13 counties total, just like we do. And so we're all hubbed at the coalition.
Okay. So the mission is to bring people and organizations together to reduce youth substance abuse and violence through education and prevention strategies in the county. So you have funding through the State of Tennessee Department of Mental Health and Substance Abuse Services block grant, the Office of National Drug Control Policy, and then in-kind contributions and local donations.
Right.
Okay. So I was interested in just some of the things that the coalition has been involved in is banning, I guess, working with cities to pass laws, right? Banning like synthetic drugs, zero tolerance in Franklin County schools for synthetic drugs, drug disposal programs, do some work with liquor stores for ID scans, and working with people that are selling alcohol so that they don't sell to underage buyers. I know that's probably not your guys' area, but just some other things.
Not mine and Josh particularly.
Right.
I
just wanted everybody to know the.
Yeah, we're still super excited about it, though.
Yeah.
Yeah, absolutely.
I wanted to give the number if there's anyone interested in talking to Stephen and Josh this morning. Our number is 967-2201. What are some common concerns that you hear from students, parents, teachers about drugs?
One we just heard yesterday during the training was that there's not enough support for the children of drug-addicted parents who get arrested. Say DCS comes in and takes a child from the home, they're put through the ringer, and they are offered through DCS is doing a great job at offering them support, but with that traumatic experience, it's just not enough for those kids, and the continuum of care is not always there. I feel like, and I don't know a lot about that, but I know it's a concern of teachers and some of the other community members.
And specifically when it comes to the mental health concerns and making sure they're getting the support and the therapy that they need, because there's also been concerns addressed about where the parents, when they're incarcerated, they're getting some sort of treatment, and some programs are starting to be implemented where they get parenting classes and things like that. What's going on with the kids and whoever they're staying with on the outside to make sure that they're getting the same kind of support, to make sure everybody's on the same page, and to make sure the kids are being kept up with psychologically, to make sure they're not going to have any shortfalls or problems. And another big concern that we have heard over the last few weeks is the age group, the target age group for substance abuse and where it's starting. Younger and younger. We're finding more and more that it's starting in middle school. And a lot of people think of it starting up in high school. Well, we're getting reports of kids all the way down to 6th grade who are going to school passing out drugs.
Wow.
And that's a huge concern, because the target started in high school, and then it just seems the age is getting lower and lower and lower. But it always seemed to be there was a gap in middle school anyway with programs. You'd have DARE in elementary, and you'd have programs from law enforcement teaching the younger kids, and then there was this gap in middle school, and then you had programs trying to be implemented in high school when kids were having drug problems. Well, it seems that we're missing the middle school age, so now all the programs are focusing starting younger so we can bridge that gap to start, because the kids at that age, they don't know what they're getting into. They're just they're getting a hold of it thinking it's something cool or fun or whatever, and then before you know it, they're in high school and they're having addiction problems.
Where do they get the medications to start with? Do they get those from their parents' drug cabinet, or it just...
The story we heard the other day, and I won't tell you what county it was in, but a kid came to school 6th grade.
6th grade.
Passing out buprenorphine strips, Suboxone strips, where she actually got that from her mother, or he got it from his mother.
From her mother.
Yeah.
That she was in treatment for
She was
drug addiction.
assisted treatment program.
Mm-hmm.
Yep.
So
I don't even know what those are.
Oh, yeah. Like Josh was saying earlier, Suboxone is another opioid that they're using as a maintenance program to kind of get people off of heroin or fentanyl or anything like that.
But it comes in a strip.
Mm-hmm.
Okay. What do you do with the strip?
You just put it on your tongue, I guess.
It's a sublingual style.
Okay.
So you put it under your tongue and it dissolves. They also have a pill form of the Suboxone, but it's still an opioid. It still acts on the same receptors as other heavier narcotics, and
we always tell people you can still overdose on it.
You can still overdose on it, absolutely.
So when you go into a school and talk to kids, what kinds of things do you? Is it just saying no, or
No. We don't. Me and Josh particularly, we don't go into schools and talk to kids specifically. We like when we say we go into schools, we're training teachers and school nurses on how to save one of their kids' life if they did get exposed to some kind of opioid and overdose. You know.
Okay.
No, the programs are nothing like DARE or Just Say No. Because when we educate the kids about drugs, we're just educating them about drugs.
Okay.
We're just making them drug experts. What we want to do is educate them about addiction, and the reality of drug use and the consequences behind that. The programs that we have set in place are evidence-based programs, Botniv, moral recognition therapy, and those are like cognitive behavioral, teaching the kids how to make better decisions, how to see themselves as individuals in tough situations where they feel peer pressure and stuff like that.
So that they're empowered to make
good decisions. Because you tell kids this is bad, don't do it, and then you don't teach them what to do.
Okay.
So.
Good. That sounds interesting. No phone calls. Okay. Well, we'll see. I'm learning a lot. I hope y'all are too out there. Okay. Let's talk a little bit about the state of Tennessee. We said as far as deaths are increasing, and any insight into state programs or issues different than what you are doing on a state level? Pretty much.
Programs like other state programs that other than the state targeted response grant that we're on. I think they're beefing up the Tennessee Lifeline to have more peer recovery specialists, to offer more support to more people who are struggling with addiction, to make those recovery community connections stronger and more widespread than they are at this moment. And the lifeliners that they have now, that's what we call them, the peer recovery specialists that work for Tennessee Lifeline, is we call them lifeliners. But there's I think only 10 throughout the entire state.
Okay.
And the one, Alan, who we work with, he covers 13 counties just like we do. It's a hard stretch. But those guys are doing a great job. But that program is actually really effective in the recovery community, and that's obviously not prevention, but recovery. But it takes all of that. It takes prevention. It takes recovery. It takes law enforcement. I wouldn't be clean if I wouldn't have gotten arrested. So some people say, well, we're not going to arrest our way out of this problem. Well, no, but we're not going to just treat our way out of it either. It takes everybody.
Okay, it's multiple approaches, and it takes a lot of money.
Mm.
I just want to say in Tennessee, in 2014, the Tennessee legislature voted not to use federal funds from the Affordable Care Act to expand Medicaid. We were one of 18 states to not accept additional federal funds, and I've talked about this before on our program on Medicare for All. In 2016, there was a recommendation made in the legislature to allow the use of these federal funds to cover uninsured Tennesseans with mental health and addiction problems, but it was never acted on. We have 1,600 people in Tennessee died from drug overdose in 2016. Now there is some legislation going through the state, the Capitol. Governor Haslam has proposed $30 million to focus on a two-pronged approach, addiction prevention and rehabilitation. $5 million for addiction prevention, that is focusing on providers, limits to the number of days a prescription can be provided for an opioid naive or someone that's not been on an opioid before. This would be injuries, post-op surgical patients, and how much of a medication could be ordered at that time. And there's been some compromise on that. Also some things about a database for, in other words, you have a patient come in, you can check on a database to see if they've been doctor shopping or if they've been filling prescriptions at a variety of pharmacies. That's in place in the state. And then also how much education for the patients as far as the dangers of opioid addiction and non-opioid pain measures. So that should be coming through before the end of this legislative session. $25 million then is proposed for rehabilitation, and there's less information on that. So one thing that I know has been under discussion is rehab and recovery centers throughout the nation. This is an opportunity for some businesses to exploit desperate people. And so I appreciated your comment to have evidence-based treatment centers. Some things work, and some things we don't know if they work or not. On a national level, I have two statistics, 42,000 deaths in 2016. Does that sound right? Have you heard that for national deaths due to opioids? And ER visits up 30%.
30% across 45 states
in
54 areas.
Okay.
Yep, that's
between July of 2016 and September
2017.
Okay, good. I got that right. President Trump in October declared a 90-day public health emergency to urgently mobilize the federal government to tackle the opioid epidemic. This was renewed again in January because there had been some question as to whether all that could have been done is being done. I just wanted to do a little brainstorming, with our audience and with Josh and Stephen about, if we had $10 billion to fight opioid addiction, what could we do? What are all the things that we could do? How about advertising to spread awareness about addiction?
Yeah, I think the more education about opioids and opioid addiction and opioid overdose is really good. I think education is a key component in all this, because it happened because we didn't really know, in the beginning. And, a lot of people don't know the dangers of taking opioids when they get it prescribed to them. And even like you said in the beginning, we were fed misinformation. So we didn't know. So I think education is a big factor.
How about things to kind of stem the flow of drugs into our country. We talked a little bit earlier about how the kids maybe get drugs from their parents, but there's a lot of fentanyl coming into the country, a synthetic opioid. I read that it doesn't all come from Mexico, that many times the drugs come through legal ports. It's just, brought in. Money for Customs and Border Protection agents. Research into non-opioid pain management.
Yes, I think that's a great.
Do you want to speak to that a little bit?
Josh will probably tell you better than I can.
I'm a firm believer in pain is subjective. It's what you make it in your mind. So education first off on what's expected in pain management. And I have personal experience with this because I was in a motorcycle wreck back in 2014. Okay. I've had a major back surgery and I've had 3 knee surgeries. And for 90% of it, I didn't use any kind of major pain management other than just dealing with the pain. And I have an extremely high tolerance for pain now. And like I said, I think the mindset of society has become we want the pain to go away completely instead of just making it manageable. And that mindset is what starts pushing people in towards dependency and addiction because the pain's never going to completely go away. The only way to go away is to go to sleep, and then people overdose and they die. So you have to teach people first off how to better deal with their pain and how to be mobile and how to get up and move around and how to let their body use its natural endorphins to deal with the pain, use its natural opioids that it produces on its own to bind to those receptors. And the more you move your body and the more you teach your body to deal with that, the better off you'll be in the long run to do it.
So movement.
And that's education. That goes back to education.
Okay. Heat, ice, elevation.
Yeah, all the stuff that they used to do diversion that they just don't do anymore when it comes to those kinds of things. And
instead of lying around dwelling about the pain, you
don't have
do something.
Yeah.
Just give me a pill and let me go.
Right.
Exactly.
And that's the mindset. And then, and there are the NSAIDs and ibuprofen and Tylenol and things like that have mild effects that don't act on those same receptors. They work by different mechanisms. They have other side effects if you take too much of them. Of course, it hurts your liver and everything else. But you learn to manage the pain rather than try to get rid of the pain.
And Stephen, I worked in medical practices, and when there's a lot of pressure to see so many patients in so much time, and as a provider with oncology, cancer patients, and family practice as a nurse practitioner, they just keep coming, and you get tired, and you have 10 minutes, and the last patient took you half an hour, so this one you have about 3 minutes. And it's hard to take that extra time to convince someone to not take a pain medicine. It's like antibiotics, too. So I think a lot of education about, other methods like we just talked about is, to have that outside of the one-to-one discussion with your physician would help us a lot. Like the antibiotics. I mean, there's a lot of not paid advertising, but a lot of discussion about how overuse of antibiotics, could harm us. And so, to be treated, a lot of things are viral.
Lots of antibiotic-resistant bacteria. But it's the same, you get enough opioids in your system and you start building up resistance to it, and your body just stops making its natural stuff, and then you try to come off of it and you hurt 10 times worse than you did when you went on it.
Right. And there's some discussion whether the opioids really do have a place in chronic pain. That they really do help. It is more of a dependency, for that. I think that there was a trend that I think, despite education, this is still happening, where a sprained ankle could get you a month's supply of an opioid. Stephen's raising his hand. That's happened to him.
That's how I got addicted to opioids.
Okay, right. When I was in college, everybody was getting their wisdom teeth pulled, and I was in a sorority where all the girls were with ice packs, and they all had, Tylenol number 3, which is a hydrocodone. So I think a lot of dental procedures, you get a lot of pain medicine. It was just easier to write one prescription for a month, and then you wouldn't have the patient calling back in. So those are definitely some trends that need to change. Josh, you want to tell us what Narcan is, naloxone?
Absolutely. Naloxone is specifically what me and Stephen deal in. We go out and we teach people about it and how to use it and what it does, and it is the opioid overdose reversal drug. And what it does is it has what's called a higher affinity for the opioid receptors in the brain that the opioids bind to, and it kicks them off. Because what happens in an overdose is too many receptors get bound by too many opioids, and it puts you in respiratory depression. You stop breathing. And then after you stop breathing for so long, you die. Your heart stops, your brain starts losing oxygen, and you die. So what this does is it kicks the opioids off receptors, and it keeps them bound for a short period of time so emergency medical personnel can get there to get them to the hospital to advance treatment so they can survive. Because if they stop breathing for long enough, they're going to die.
And it does that pretty quickly, is my understanding.
Within a few minutes, they have several different forms. They have intramuscular shots, they have IV, and they have intranasal. And even the push today in emergency medicine is shifting from the intravenous to the nasal because it's faster to give. You don't have to get an IV, and it works within 2 to 3 minutes.
So I've heard things on the news about paramedics being called multiple times to a home for either the same individual overdosing or other family members. Have you encountered those situations? So
the key to that is when you give somebody naloxone to reverse an overdose, it is imperative, and we educate on this when we do our class, that they go to the hospital.
Okay.
Because the naloxone only lasts 30 to 45 minutes, and that's best case scenario depending on how many opioids they took and how potent they were. And after it wears off, you just said it yourself, opioid narcotics last 4 to 6 or up to 8 or even up to 3 days, depending on what form they're taking and how they're taking it and how much. So there's not a narcotic in the world that lasts 30 to 45 minutes. So once that naloxone wears off, if they're not where they can be treated by medical professionals, they're going to die all over again.
Okay, so they wouldn't necessarily be taking another narcotic, but the same one
it's still in the system. It's still in the system floating around. And people who are opioid dependent, they don't like getting naloxone. It's not a good experience for them because it blocks all the opioid receptors in their brain. So they go into instant withdrawals. A lot of times if they're opioid dependent and you give them naloxone, the first thing that's going to happen, they're going to wake up, they're going to look really cruddy, and then they're going to vomit. And then after they vomit, they're going to be hurting, and they're going to probably be a little angry because they're shaking, they're having withdrawals, they're having all the withdrawal symptoms that they didn't want to have, the whole reason they took those high-level doses. So it's not a pleasant experience, and it's not something that they want to happen over and over again. They don't realize it until it happens. And they say, oh, I'm fine, just get it, leave. And then if it happens all over again, the second time you wake them up, they're not pleasant because it hurts. It's a very painful experience for them. But would you rather them be dead or would you rather them be alive and not feeling so good? It's kind of the...
What is the availability of Narcan for the public or family members or...
So the FDA did approve Narcan for over-the-counter sales in pharmacies nationwide. And you can buy it over the counter without a prescription and carry it around with you all you want, but it costs on average, I think the last time we had somebody tell us it was priced at a little over $130 at the pharmacy.
For one dose?
It's a 2-dose pack.
2-dose.
Comes in a box for 2 doses. And you can also get it through prescription, and from what I understand, it's like a Tier 1 prescription through TennCare. It's $40 or less, or even free in some cases, depending on what insurance you have. And insurance and pharmacies will fill it off a prescription. And Stephen, he knows a little more about that than I do because
they need a pre-authorization, right?
Yeah, that's right. We've had people come to us saying that they couldn't get their Narcan prescription filled, and there's 2 things. A lot of the smaller pharmacies that aren't chain pharmacies had trouble getting it to process their insurance. So, you need to go to a bigger pharmacy because they're the ones who are able to process it. I don't know what the problem there is. I just know that's an issue. And like he said, another issue is the doctors have to call to get a pre-authorization a lot of times from the insurance company to go to the pharmacy before the pharmacy can fill it. Because that's something the doctor's office has to do. They call the insurance company and get the pre-auth, and then they have the number saying the insurance will pay for it, go to the pharmacy, give them the script and the pre-authorization, they get it filled. And education in the doctor's offices that they have to do this, or making sure that they take the time to do this, is a big thing, because there are several patients we've gotten calls from that said, well, I got my prescriptions and I couldn't get my naloxone filled because they said I would have to pay out of pocket for it. And some of it has to do with what pharmacy they're using, and some of it has to do with the pre-authorization from the insurance company.
So there's some barriers to this life-saving treatment.
And it's a lot about education.
But they, individuals who can't receive that from the pharmacy, they can come to us and go through our training. We'll give them a certificate. We'll give them the training for free. We'll give them the Narcan for free.
Okay.
And we've done that all over Region 5 South. In every county so far, we've done that. In all 13 counties, we've provided to law enforcement, laypersons, medical professionals, schools,
volunteer fire departments.
Even did a training at a church.
Okay.
We reach out to anybody and everybody in our region that wants it, and we'll gladly do a class and get them what they need. And if they feel like they're in contact with somebody, or they feel like they have a family member or a friend they know that's at risk for overdose, and then throughout that we say, hey, if these people want treatment and they want help, get with us. We'll get you with our lifeliners, and we'll try to find recovery options for them. And we just keep pushing until we can get them into recovery.
Okay. What would a recovery program kind of look like, or maybe Stephen, what your recovery program, if you'd want to talk about that, or you can go generic on
I did a 12-step program. I went to a secular treatment center, and they didn't really do any evidence-based stuff other than a little bit of CBD or CBT. Did I say CBD?
I don't know, what does that stand for?
Oh gosh. Cognitive behavioral therapy.
Oh, okay.
And a little bit of that, but mainly what they did was a lot of behavioral modification. Really, it was a very structured program. It was, you went to the bathroom between classes. You had classes all day. We're constantly in therapy groups or 12-step meetings like AA, NA meetings, that kind of stuff. And then also educational things like, before I went to treatment, I didn't really understand addiction on the brain. I had no clue about it. But by the time I left, I was there 68 days. I was an expert.
I bet.
Because you spend 26 years wondering what's wrong with you, and then somebody finally tells you, you kind of pay attention. But they offered that, a lot of education, and it was 68 days. It's a 60 to 90 day program. And
were you inpatient, or were you going back and forth to your home?
Inpatient.
Inpatient. Okay.
And I was court ordered, so I had, a program when I got out. It was the Franklin County Recovery Court program, or the 12th Judicial Recovery Court program. And I see a lot of successful people go through that. I was one of them. We find that most rehabs that we know that the brain, 90 days it takes for the brain to come back online.
Oh, really?
Even start making decisions. Again, 28-day programs just don't cut it.
Okay. Okay, that's interesting. Do we have a question?
Yes.
And I was going to kind of come around to this. We have a question. What do you do if a patient thinks their child is on drugs? I was going to ask about your free testing, kits, too, when we were talking about. But you guys want to address that question? What do you do with patients?
You can,
parent, if a parent, not a patient. Parent thinks their child is on drugs.
We offer, the coalition has a program where they give away free drug testing kits and lock boxes for your medication. Those lock boxes aren't going to keep like a teenager out of them or anything like that. But a small child, it just creates another barrier for, a child to get a hold of medication or anything.
But yeah, if you suspect that your child is on drugs and you want to get a drug testing kit that we have, you can give us a call at the coalition and come down, and we'll hook you up with one. And if they are, then we can try to give you more information about how to approach that and the best way to try to handle it, because it's really hard to handle it with kids if you don't know, and sometimes they could be acting out, or sometimes they could be having other problems. So
there might be some other signs a parent might see that they're...
It just depends on the substance they're using, because like you're in the medical field, as you know, different substances have different effects. You have stimulants, you have depressants, you have things that can make you just kind of relax and high. You have things that can put you to sleep. You have things that can wire you up and keep you awake for days. It just depends on what they're using. Mm-hmm. So the biggest thing is just a change in behavior, a sudden big change in behavior that is consistent, and you'll see it more in certain times, or if they've been at home for several days and they're not using anything, and they become more agitated or more problems because maybe they're becoming dependent on the substance. There's just so many different things to look for. But if you have your suspicions, I would go with your intuition, and if you want to try to get them tested or figure it out, then you're welcome to.
And if it turns out they are, we got programs for that too.
Yeah.
Okay, excellent. I heard about failing grades or moodiness, and
you got to weed out what's behavioral and what's otherwise.
Age, I guess, dependent.
Yeah.
And I know when we talked about gun safety a few weeks ago. Discipline and knowing what your kids are doing, and that they don't know anything about where the gun is, and we just don't know a lot about what our kids are doing. Sometimes it's kind of a secret world, so it takes a lot of watching after. That was a good question. Thank you. Are there hospital guidelines for release of overdose patients? So when the paramedics take them in, are they hospitalized for some time, or are they referred? Or
I think that because when I was a paramedic in Alabama for many years, and I know that they take them in and they keep them for at least until they know that they're out of the overdose threshold.
Mm-hmm.
And if they have psychiatric issues, then they'll try to admit them to psych. But, as far as in hospital, there's not any recovery options inside the hospital for emergency medicine. So there also has been a shift to start educating providers to say, we need to get recovery specialists in the hospitals for people that are having addiction problems or overdoses, to educate them in the emergency room to say, hey, they're about to let you out. Let us help get you into treatment.
Mm-hmm.
And so there has been a shift recently to try to push those options in the emergency departments, because we know that's not the job of the emergency departments. Their job is to save people's lives and keep them alive.
Mm-hmm.
And then that has
been
a problem.
For the next one.
Right. And like you said, it's fast-paced.
Mm-hmm.
So to give them the resources to say, hey, here's a number you call if someone comes with an overdose. We can get recovery specialists in there before they leave and say, we're going to help you get into recovery if that's what you want to do.
Okay. With that, as we kind of ready to wind up here in the next 7 minutes or so, do you want to give some phone numbers and how to reach y'all?
Sure. You can reach me, Stephen Mason, at the Coalition. The Coalition website, it's fcpctn.org.
Mm-hmm.
And
you want help with your phone number? Because
no,
I have that here.
And my phone number is 931-636-0147.
And Josh?
And my phone number is 256-606-6143. And if you give us a call, if you have a question, if we don't know, we'll find an answer. If you need resources that particularly we don't deal with, we'll find somebody. We'll do everything in our power to help you.
or you can just come on down to the Coalition headquarters, Campora Family Resource Center, at 900 South Shepherd Street.
And we have people show up all the time. It's quite all right.
Oh, good, good. Okay. The legislation in Washington pending. The House has several proposals. They're hoping to have some bills for discussion by Memorial Day, and in the Senate, a committee led by our own Senator Alexander has been hearing expert testimony on the issue of our opioid crisis, which is good. That's what they're supposed to do when an issue is very complicated and they don't know everything there is to know about it. So looking at, again, money for the problem, I think trying to coordinate all the efforts of the different federal and state agencies to get help out to people probably needs some work done on the national level. One thing we talked a little bit, just touched on, Stephen, you said that, and none of this would have happened for you if you hadn't been arrested. What do you think about the plan to increase punishment, severely punish drug dealers? Do you think that would help? Where on earth could we start with that?
I know it. You really look at. Okay, so we've got the world's largest prison population right now.
Mm-hmm.
You know, we tried just arresting people, capital punishment, and you know, I believe that people should be held accountable for their actions. But 98% of our prison population, as of 2010, was addicts and alcoholics.
Mm-hmm.
For some sort of drug charge or alcohol charge. You know, so you think, and a big great portion of those were people who trafficked and dealt drugs, and those people also, you know, when you look at that, what percentage of people are struggling with substance abuse disorder themselves?
Mm-hmm.
You know, part of Governor Haslam's bill that he just passed was opening up, I think, 512 beds in a prison in West Tennessee for rehabilitation. You know, I feel like we're moving in the right direction. I think what you're referring to was a comment that was made about the death penalty for drug traffickers.
Mm-hmm.
It would be an effective deterrent, but I'm not voting for it. So
I don't think it would, you know, hit or miss. It would deter people, but you'd have to execute a few people before it would deter anybody, number one. And number two, are we really fixing the problem? Because I don't want to get into Stephen's business, but if that were the case, Stephen wouldn't be sitting here right now.
Yeah.
So. Because, well, you do whatever you have to do to support a habit. And when stealing doesn't work, and when trying to get money wherever you can doesn't work, you resort to trying to sell whatever you can, including drugs. So you have to weed those out. How many people are trafficking large amounts of drugs that aren't actually drug addicts, and how many people are just addicted and part of this vicious cycle where they're just trying to feed their own addiction? And so that's a big determination that would have to be made. And
yeah, I don't think it would.
But like I said, I told you earlier, you know, politics are going to do what they're going to do. The best thing people can do is educate themselves on the policies and educate themselves about voting and contact the representatives on what their true feelings are after they're well educated on it. And then they need to educate their communities and their families to try to prevent this on a different level. Right. We're here to save lives.
That's right. These gentlemen are here to save lives, and I think they're doing all they can. What if someone wants to support financially your efforts in the community? What can they?
I don't know. I would say if you want to get involved, or if you want to support financially, I would come to the coalition meetings, and we have that every third Monday of the month at Campora Family Resource Center at 11, 12.
at
12 at noon. And there you would, if you were someone who was interested in supporting financially, you would meet some of the people sitting at the table who run, who are doing things like clothe the homeless or house the homeless, or and that's a big portion of what we do, you know. I'm so and so starting a recovery support group, and you could support that financially, or support any number of nonprofit groups. And you know, we do need support. Every program out there needs some kind of support. You know, we don't do this with money; we do it with people. So
great. I want to thank Josh Cruz and Stephen Mason from the Franklin County Prevention Coalition for sharing with us today about the opioid crisis. We've talked a little bit about things on the national level, but more importantly, Tennessee and our own Franklin County. So I thank you so much. We'll be back the second and fourth Thursdays next month for Common Sense Matters. Thank you.